healthcare medicine is a peculiar portion of medicine, in that we tend to walk into unknown situations with very little prior knowledge of the circumstances. When arriving on scene and to the patient, it's important to introduce yourself and your partner and ask for permission from your patient to treat them. In this specific situation, when attending a delivery, ask your patient if it is okay for you to take a look to see how far the delivery is progressing. When visualizing the vagina, you are looking for crowning or any other presenting limb, any excess bleeding, any meconium that's present, whether the cord is prolapsed, or if there is any other abnormal signs during delivery. Questions to ask mom. Is this your first pregnancy? How many births have you had? How many children do you have? Any complications during this pregnancy? When is your due date? What week are we at in your pregnancy? When was the last contraction? And how long are they lasting? In this scenario, this patient is exhibiting symptoms of shoulder dystocia, also known as turtle sign. This is seen by progressive delivery of the head on contractions, and then a sudden stop due to the baby's shoulder getting stuck on the pubic symphysis. Risk factors for shoulder dystocia include gestational diabetes, previous history, obesity of the mother, more than 42 weeks gestation, and maternal diabetes.
Mom! Stuck.
Management of shoulder dystocia includes the acronym ALARM. A stands for ask for help. L stands for lift the legs, or put the patient in the McRoberts position. A stands for adduct the shoulder and apply suprapubic pressure. R stands for roll over onto the hands and knees. And M stands for manual delivery of the posterior arm. The procedure is as follows. Once the head is delivered and you have recognized shoulder dystocia, most commonly by the turtle sign and the presence of the risk factors, you need to ask for help. Put the patient into the McRoberts position, where both legs are flexed backwards and suprapubic pressure is applied to try to release the shoulder. If the baby does not deliver in this position, roll them onto all fours to allow the movement to hopefully dislodge the shoulder. Attempt manual delivery of posterior arm by sliding the baby's arm in front of his body. If this does not deliver the baby, attempt alarm for the second time. The baby should be delivered within 5 minutes of the initial attempt. If both attempts fail, prepare for transport. Shoulder dystocia is a risk during pregnancy and can lead to both fetal and maternal complications. Some of the fetal complications are brachial plexus injury, which is the most common injury, occurring in 4 to 40% of cases. This is damage to the nerves in the brachial plexus located in the shoulder, causing injury to the shoulder, arm, and hand. It could cause limited range of motion, pain, or detachment from the spinal cord. Fractures of the fetal humerus and clavicle can occur. It generally happens within 10% of the cases, and usually heals with no side effects. Hypoxic and ischemic brain injury are also reported, and the risks correlate with the duration of head-to-body delivery, especially with a time greater than 5 minutes. Maternal complications include postpartum hemorrhage, which can be managed with direct pressure if external and bimanual pressure while the placenta has not been delivered, or fundal massage if the placenta has been delivered. Vaginal lacerations are common as the baby is often much larger, and uterine rupture may also be a complication maternally.